I want to thank all of you for allowing me to talk to you just briefly today about perinatal substance use screening and testing. Many apologies for my inability to be present with all of you today for this discussion. So I want to just go over briefly some of the limitations and concerns specifically related to utilizing urine toxicology to guide perinatal substance use identification and treatment, and then talk just a little bit about another state's model that might be an alternative for reporting of prenatal substance exposure, or PSE, here in Minnesota, if particular statutes were modified. So I want to begin by sort of talking about the language that we use and specific, what is substance use screening? When we talk about screening, that is using a validated written or verbal screening tool. This can be something that the patients complete ahead of time. They do it on an iPad, you talk to them. That's really identifying folks who are at a higher risk for non-prescribed substance use. So this is a short tool that's been validated, and then you can go into further detail with those individuals who screen positive. In general, the data suggests that about 15 to 20% of the population will need additional conversation after they're given these screening tools. So a large part of your birthing population is going to have a negative screen and won't need any additional discussion. The second thing that we're going to talk about really related to Minnesota statute is biological testing. So when you talk about biological or toxicology testing, that's testing of some sort of biological material, whether that's birthing person urine, meconium, cord segments, for substances and their metabolites. And this is for both non-prescribed and prescribed substances. So I think it's really important, and I think this is a lot of the work that the task force is doing. We really need to identify what are our goals as healthcare providers for prenatal substance use toxicology testing? And I'm not saying that I have those answers, but I think these are things we need to think about. How does toxicology testing, as required by state statute, help birthing patients? How does it help newborns? And I think also, as equally important, is how does it harm them unnecessarily? So I think it's important to set the stage when we talk about substance use disorders or addiction. Approximately 20% of the US population has past year non-prescribed substance use. There are differences in use between different race and ethnicity groups, but by and large, the rates of substance use disorders, which is what we're trying to identify, are very similar across identified race and ethnicity groups. So I think that's very important when we look at who is being tested and who is being identified. So I just want to quickly talk about two cases, and these are very real cases that I think those of us who work in labor and delivery or in birth centers have seen kind of roll out before. So a Black birthing patient presents with vaginal bleeding in pregnancy and undergoes an emergency cesarean section for placental abruption. This individual was not screened for substance use with a verbal or written screening. A urine toxicology test was performed without her consent, and that is in fact positive for cannabinoids. Child Protective Services is contacted and evaluates the patient and her infant in the hospital. The patient leaves the hospital the day after delivery and does not return for any post-delivery care. In contrast, a white birthing patient presents with very similar vaginal bleeding and also undergoes an emergency cesarean section for placental abruption. There is no screening or urine testing done for substance use. She is discharged home 3 days after delivery and follows up at both 1 week and 6 weeks for routine post-delivery care with her health team. Now, here are two very identical clinical situations, but not identical patient care, not identical in who was administered urine toxicology, very similar in neither one having validated screening, and disparate testing and reporting, which led to disparate clinical care and certainly lack of trust by the first birthing person and no follow-up for care after delivery. So when we talk about perinatal substance use, we know that state law requires in certain situations that we do toxicology testing at birth. It would seem that the goal of this is perhaps to identify individuals using substances at the time of delivery in that end part of pregnancy, or perhaps to identify infants that might need extra treatment. But in fact, we know that the effects are that individuals will avoid perinatal care. So perhaps some of the risk factors that they know they've been tested for in other pregnancies or they've seen other folks that they know be tested for might not be identified. And we know that when people do not present for prenatal care, that they do actually have worse outcomes. And Minnesota's statute really remains very vague on when we should be performing this toxicology testing. And so we know from conversations and discussions that every health system does this a little bit differently. And birthing people with identified prenatal substance exposure, whether we like it or not, are at risk of arrest, they're at risk of loss of child custody, they're even at risk of forced commitment or confinement if they are not ready for the type of treatment that may be identified as the best treatment for them for their substance use. So here is our statute. I know we've all reviewed this before, but I always want to highlight that the reason we're supposed to be doing toxicology testing is if a woman has obstetrical complications. So those are pregnancy or birthing complications that are a medical indication of possible use of a controlled substance for a non-medical purpose. So I think really when we are trying to identify when does this law require testing, we need to identify obstetrical complications. So as we go through this talk today and we look at what indications are associated with substance use, when we're looking at using this testing, are those indications actually obstetrical complications? And if they're not, are there in fact any obstetrical complications that would require us as healthcare providers to perform toxicology testing? So I also want to remind everyone that there is absolutely no large perinatal organization which supports the use of toxicology testing, either universal toxicology testing or risk-based toxicology testing. And in fact, the four major perinatal organizations who are involved in perinatal substance use care recommend a universal screening tool. This is not something that's done in the state of Minnesota. And again, I think that's really important to contextualize what is the national standard of care, both by addiction medicine groups, OBGYN groups, high-risk pregnancy groups, and pediatrics. So are there obstetrical complications that are a medical indication of possible use of controlled substance for non-medical purposes? And I think when we think about those, we want to also talk about the inequities that multiple studies have identified really over the past 10 to 15 years related to toxicology testing in pregnancy. The only testing indications repeatedly identified in studies that are associated with an increased likelihood of a positive toxicology test. So those indications that have an increased likelihood of identifying substance use are a prior history of substance use or a current history of substance use. These are things that would be identified through validated screening, that verbal or written screen tool that we would recommend. I think it's important that when we look at these studies, and this is kind of a compilation of all of the studies listed below, one study has found that, in fact, Black and Hispanic birthing people are 5 times more likely than white birthing patients to undergo toxicology testing for indications other than substance use, for indications that have not been associated with a higher likelihood of positive testing. Another study showed that Black birthing people and their infants were 1.5 times more likely to be tested for non-prescribed substances, despite no association between race and a positive test result. And in another study, Black birthing patients were 33% of those who were tested, but only 6% of the birthing population. And most importantly, they were not more likely to have a positive toxicology screen. And so I think this really highlights that there are very significant inequities related to race that are currently identified in multiple studies in the United States related to toxicology testing surrounding pregnancy. So what about in our state? So we don't have large published studies or a cohort of health systems who've compiled their data. What we do have is this very preliminary data that I've had the honor of working on with one of our residents at the University of Minnesota. And this is in a single health system, 3 hospitals in very different settings, urban, suburban, and rural, and combining those to look at urine drug screening during pregnancy. That top red circle highlights the percentage of patients who had urine drug screening before they came in for delivery. So what we see there is 5.6% of white birthing patients had a urine drug screen before delivery. 6.9% of patients who were identified as other, those were all grouped together, but 15% of birthing patients who identified as Black or African American. More importantly, when we look at that urine drug screening at delivery admission, which is the bottom red circle, we see that 12% of white birthing population, 18% of those who identify as any other group that's not white or Black or African American, and more than 1 in 4 Black or African American birthing patients are undergoing a urine drug screen at delivery admission. Now, we have yet to further break down these data looking specifically at substances or correlating positive tests, but I do think that this highlights an important inequity in who is getting these screenings. So again, we want to talk about screening. When we really think about the term screening, screening is a strategy to identify an unyet recognized risk. And the goal of screening is to identify people who would benefit from additional care and resources. Is this really what toxicology testing or screening achieves currently in the state of Minnesota? We know that biological toxicology testing, so what we will typically call urine drug screening, is not substance use screening, and that the sensitivity and specificity of these tests really depend on what are the cutoffs used by labs. Everybody uses a different lab. People may use a different collection method, and most importantly, what substance are being tested for. I'll give an example. 6 to 12 months ago, our hospital system did not test for fentanyl as a component of substance toxicology screening at birth. And we know that a large percentage of people who have opioid use, non-prescribed in our state, utilize fentanyl. And so there were a lot of individuals who may have had negative toxicology assessments, even though they had chronic opioid use. And so I think this is important that depending on which hospital you go to, you may not be tested for the same things. And we're really limited by substance half-life, route of ingestion, and detection windows. So we know that chronic cannabis use, chronic fentanyl use, you can have positive toxicology for days to weeks after you've no longer had use. And so I think that's important as well. In one study with universal biological assessment on labor and delivery, this has been often proposed and is used in some Minnesota systems as a way that we can find all of the patients who have unprescribed substance use. So in this particular study in 2020, 1.5% of all of the tests were positive for substances, but 47% of those were false positives. So these are patients that on the initial testing had a positive. When that confirmatory test came back, which often came back after they'd left the hospital, those were found to be negative. And this is only one reference table, but I think it's really helpful for looking at what substances can have potential false positives. I think one that we see a lot is labetalol. Labetalol is a very common medication that's used for high blood pressure. It can cause a positive urine toxicology test for amphetamines. And so you've got a patient that you're coming up to and you're saying, I know I asked you earlier, you didn't say you were using anything, but now I've got a urine drug screen that's positive for amphetamines. Do you have something to tell me? And it kind of undermines that trust if you haven't done prior verbal screening or had a conversation. So I think a table like this is really helpful to have in general, just to be mindful of how difficult it is to truly know that a positive urine drug screen is actually identifying substances that might be affecting the pregnancy. So what is a validated screening tool? We've talked about this before. I think it's important that these screening tools are significant because when they are negative, ones like this here, the 4-piece plus, there's a 97% negative predictive value. So if it is negative, it is highly likely that this particular birthing patient is not challenged by substance use in pregnancy. And we know that the data on biological testing show that, as we talked about a little earlier, a history of substance use or a substance use disorder, and perhaps no prenatal care in other studies, may be predictive of a positive test. Now, I will take a step back and say that no or limited prenatal care, which had been a screening tool in a lot of hospitals before, really changed during the pandemic. There were a lot of folks who had challenges to getting prenatal care because they couldn't bring their other children to care. This certainly happened in the system where I work. But it is the no prenatal care, none at all, that has been in other studies been shown to be predictive of prenatal substance exposure. Placental abruption, stillbirth, preterm labor, these are ones that are utilized by a lot of hospitals within our state. Those are not consistently associated with a positive test. And most of the time, when these things happen, they are not related to prenatal substance exposure. So, how do we reduce inequities in testing? Well, there's one study published last year that showed if there was a standardized policy for urine drug testing in the labor and delivery setting, this did reduce inequities in testing by race without negatively impacting neonatal outcome. It was also associated in this particular study with an increase in obtaining patient verbal consent. Now, I will highlight that in Minnesota, there is not a requirement for patient consent or an ability for a patient to refuse. And that can certainly get you into legal or medical legal concerns when you have a patient that you've administered a test to that they didn't consent for. And so, certainly, what we know is how we should practice as physicians, as midwives, as healthcare providers in general, sometimes bumps up against a Minnesota statute. So, what are the considerations for biological testing? These are some of the ones that are more commonly identified in different national organizations or studies for reasons for biological testing. So, certainly altered mental status, when you're concerned that there is current intoxication for a substance, if someone appears actively intoxicated, if they identify that they're in treatment for a substance use disorder or have a history of non-prescribed substance use in the pregnancy, or if they have no prenatal care. Additional experts have suggested possible physical evidence of injection if they are hospitalized for some type of soft tissue infection or endocarditis, a heart valve infection related that doesn't have an explanation, that can be related to substance use quite often, and perhaps unexplained placental abruption or severe hypertension, although in general, these have not been associated with a consistent identification of a positive screen. So I just want to talk about a model that's used by one Minnesota health system that in the pandemic kind of went through and said, we seem like we are unfairly targeting folks for things that may not be associated with substance use. Can we change our standardized screening tools, or actually our toxicology testing criteria rather, to identify those patients who truly are at a higher risk of having substance use exposure? So really what this particular system did is they identified screening for birthing people and screening for newborns. And so this was using OBGYNs, maternal fetal medicine, family medicine, pediatrics. And so kind of what they found as birthing person criteria was non-prescribed substance use during the pregnancy, whether this was a maternal self-report or prior toxicology testing during the pregnancy. I think it's important that this includes excessive or habitual alcohol use. When you're doing toxicology testing for alcohol exposure, a urine toxicology test is not going to do that. Rather, there are specific blood tests that would be perhaps administered that would identify that. If someone was enrolled in substance use treatment during the pregnancy, if they had altered mental status, including a loss of consciousness or slurred speech when they presented, unexplained respiratory arrest, which we know is very common with opioid use disorder, a seizure of unknown etiology, which can be related to certain withdrawal, in particular alcohol withdrawal or benzodiazepine withdrawal, or unexplained stroke, heart attack, or myocardial infarction, or a patient who presents with cardiac arrest. For newborn screening, we had very limited criteria. Those were those newborns whose birthing person had met those criteria, but the birthing patient declined. So this is in a hospital system where a birthing person can decline toxicology screening, even though state law is not very clear on that. If there are clinical signs in the newborn that make the pediatric providers concerned that that infant may be at risk of withdrawal, and any abandoned infants that fall within the state safe harbor exception. I think it's important when we talk about providing any kind of healthcare, any kind of testing, that it really should not be performed without patient consent. The only exception certainly is a patient with altered mental status when you're really trying to figure out how to best support them. Testing without consent really could be considered adult assault, but consent is not discussed in Minnesota statute. So again, healthcare providers are put in a bind. That's quite complex. And it's important to remember that when you do toxicology screening, it should be followed by confirmatory testing before a report is filed. So let's talk a little bit about the Connecticut model. So Connecticut has now published on a novel protocol for reporting substance exposed infants. And so I've got the website link listed here. And I think it's important to know that this reporting infants for prenatal exposure really started in 1974 when CAPTA was originally enacted. It was reauthorized in 2010 and modified in 2016 to more focus on opioid exposure and substance exposed newborns as well. And so what Connecticut did in 2019 is they changed their hospital reporting infrastructure at a statewide level to divert cases of prenatal substance exposure that did not have safety concerns, but did have a plan of safe care, or what they are now calling a family care plan, for how someone who might be challenged by substance exposure might be able to provide the best supported care for their family. And they have an online system with de-identified information. And what does this mean? It really means that since 2019, you have a setting where each family is evaluated, preferably prenatally, and they're identified as having substance exposure or being at risk of a substance use disorder. And there's a plan of safe care that is developed preferably with the birthing person. And when they present at birth, if there are no concerns of abuse or neglect, that birthing person and that birth can be identified and reported in a de-identified fashion. So the birthing person's name and identifying information is not there, but the hospital simply say, hey, we had a case of prenatal cannabis exposure, but no neglect or abuse concerns were identified. And the family has a written family care plan. So they have to have both no identified abuse or neglect and had this care form filled out. And this is what that care form looks like. That would be sent to the portal notification. It's pretty lengthy. I want to identify these are specifically kind of what they go through to identify any concerns for abuse and neglect. And this is typically going through their social workers, although it may be a midwife or a physician that's contributing as well. And this is their family care plan. That's what they're calling their plan of safe care in Connecticut now. And this kind of goes over, preferably completed with a hospital staff member or a physician or a social worker and the parent and caregiver. So you can see at the bottom of that first page that the parent or caregiver or birthing person would be signing this as well. So I think that it's important as we close to really think about um, understanding kind of the limitations of the task force, but the power we might have to provide suggestions to the governor's office and also to the legislature. This study in 2022, which looked at child abuse policies, prenatal care, and substance use disorders, looking through a pregnancy risk assessment monitoring system and looking at births in states that had a child abuse policy. So Minnesota would be included for that. That prenatal substance use is considered child abuse or neglect, or a mandated reporting policy at some point during the pregnancy, or both. And this study found that in birthing patients who had substance use in pregnancy, who delivered in states where one or both of these policies existed, those folks tended to have later initiation of prenatal care and a lower likelihood of adequate prenatal care and postpartum health care. Why does this matter? Because we know from prior data that if people have ongoing substance use in pregnancy, but they continue to have prenatal care, their outcomes are actually going to be better for them and for their baby, even if they never get substance use treatment. So getting that prenatal care is such a key element for us. So I want to just kind of highlight some of the barriers to optimal care as we kind of go through our task force, and certainly happy to take questions on this at our next meeting or by email ahead of time. We have a vague toxicology testing law that doesn't standardize patient care statewide. So a patient with very same presentation can present to two different hospitals and very different things can happen. And that can be further compounded by what that patient looks like. We have a testing law that does not require informed consent or allow patient refusal, which puts healthcare providers in a medical legal dilemma. We have a state in which a medical condition, substance use disorder, is associated with mandated reporting of prenatal exposure as child abuse and neglect. And I always like to go back with my learners and colleagues and talk about the comparison with diabetes. Why don't we then report babies of birthing people with diabetes when those infants have evidence of prenatal high blood sugars? We can very easily identify those babies that had birthing people that had too high of blood sugars, because those babies have very low blood sugars after birth. And so we can identify a time where another medical condition wasn't adequately treated. but those folks are treated very differently because of the difference in stigma and legality. So I think it's really important to think about those discrepancies as we continue with this work. Here are my references, and thank you again for listening today.